Hello and welcome to this topic of recurrent abortion. So whenever you get such a case, the first thing you have to do is just find out what is the probable cause in the patient. So the main causes are immunological, endocrine defects, anatomical defects in the mother, and amongst the anatomic, septate uterus is the most common defect. 50% of the cases of recurrent abortion are unexplained. You cannot find any cause for it. Then obesity and environmental factors like smoking, alcoholism, like heavy strenuous work of the mother or some mental stress, all these also play a role. Amongst the immunological, दो तरह की कॉजेज़ हैं. एक तो एलो इम्यून, मतलब बॉडी में इम्यूनिटी फॉरेन एंटीजन के लिए है. फॉरेन एंटीजन इस केस में पैटर्नली डिराइव्ड HLA होता है विच इज़ देयर इन द फीटस, उसके अगेंस्ट एंटीबॉडी बन जाती. और ऑटो इम्यून कॉज होता है जैसे एंटी न्यूक्लियर एंटीबॉडीज़ विच आर प्रेजेंट इन SLE, केसेस ऑफ SLE, एंड यू हैव APLA, वेरी इंपॉर्टेंट, antiphospholipid antibody syndrome. So you have to rule it out. A luteal phase defect, मतलब the levels of progesterone falling in the first 7 to 9 weeks of gestation because corpus luteum is not well maintained. Okay, so that is, there is a phase defect, phase lag by 48 hours. Hypothyroidism, polycystic ovarian syndrome, where there is hyperandrogenism and hyperinsulinemia which is causing the problem, diabetes and hyperprolactinemia. These are the endocrine disorders which are related to recurrent pregnancy loss and should be investigated. So uterine structural defects can be congenital or can be acquired. Mullerian fusion anomalies की कैटेगरी में आते हैं congenital defects. तो उसमें septate uterus, uterus diadelphys, unicornuate uterus, bicornuate uterus, these are the arcuate, these are the categories. Septate सबसे ज़्यादा जो है वो common cause होता है amongst the Mullerian fusion anomalies. Acquired में अगर ileomyoma है on the inner aspect of the uterus, मतलब submucosal, which is distorting the cavity, or if there is cervical operative procedure performed in the past and which has led to cervical stenosis, cervical incompetence also will result due to it, or if the endometrium is scarred and adhesions are formed. So Isherman's syndrome it is known as, where due to heavy curettage the endometrium is all fibrosed and it is destroyed. Next in the causation, in the etiology, are the genetic causes. They overall account for 5% of the RPL cases. The most important amongst them is the balanced translocation, which is either there in the mother or the father. On the fetus which is formed, it then has unbalanced translocation. Otherwise monosomy, trisomies are also there. The management is you perform karyotyping and you can find out whether genetic defect is there in mother or father. If it is there, then what else other than counseling and ART? Otherwise they can be explained about the importance of taking folic acid during pregnancy, and of course counseling and tender loving care is the management. Then infections. So infections, वैसे तो टॉक्सोप्लाज्मा और रूबेला और साइटोमेगालोवायरस एंड ऑल दैट बहुत ज़्यादा उसको हाइपर इम्पोर्टेंस दिया गया. देर इज़ नो प्रूफ ऑफ डायरेक्ट रिलेशन एंड डज नॉट रिक्वायर टू मच ऑफ इन्वेस्टिगेशन. Bacterial vaginosis, if it is there in the first trimester, may be related to abortions and like preterm labor, but otherwise infections are not very much playing an important role in recurrent abortions. In sporadic cases it can be there. तो हिस्ट्री जब लेंगे तो मदर और फादर की एज इम्पोर्टेंस रखती है. मदर मोर देन 30 years, फादर्स एज मोर देन 40 years इज़ इम्पोर्टेंट ऑफ कोर्स. Then, because it is a recurrent condition, so obstetric history has to be taken in detail. For the past abortions that have occurred, you should always inquire what was the kind, whether spontaneous or whether it was induced, whether missed or blighted ovum, or what kind of abortion it was, whether the tissue was sent for histopathology or not. Okay, so all these things, and whether curettage was done after the this thing abortion or not. So history related to endocrine disorder, like for diabetes, polydipsia, polyuria, recurrent infections, or like hirsutism and menorrhagia in the past, for PCOS, delayed menses in the past. Okay, for LPD, shortened luteal phase is the particular thing. So luteal phase less than 13 days, suggestive of LPD. Okay, so when there can be galacturia and symptoms of hypothyroidism, like feeling excessive cold or like less appetite and all these things. Now, what is the history suggesting anatomic defect? So it can be history of cervical procedure, some DNC procedure, and like cervical lacerations, vaginal delivery in a rural setting in the past and cared for, and like it can also be history of menorrhagia, which might suggest some leiomyoma or anything like that. So, or excessive dysmenorrhea, which is present in Mullerian fusion anomalies. So start from the immunological causes, how to manage. Management consists of two parts. One is investigation, other is treatment. So for immunological, most important is APLA, which has a definite correlation also, which has a defined risk also, and it is treatable. So you have to find out so there is a Sapporo criteria for diagnosis. One clinical and one laboratory. Clinical में history of arterial और venous thrombosis हो, या फिर obstetric में अगर 10 वीक से पहले 3 मिसकैरेजेस हैं, 10 वीक्स के बाद में एक है या एक से ज़्यादा है, और 34 वीक से पहले का कोई प्री टर्म डिलीवरी है ड्यू टू प्री इक्लेम्शिया, ये क्लिनिकल है. लेबोरेटरी में एंटीबॉडीज़ IgG या IgM which are present in high titers, medium to high titers, and they are against the anticardiolipin antibodies, beta-2 glycoprotein and lupus anticoagulant, and these reports should be repeated, very important, after a period of at least 6 weeks. So that has to be done, and then you make a diagnosis. कभी भी जब एनाटॉमिक डिफेक्ट होता है यूट्रस में, तो वो मैनिफेस्ट करता है इन द फॉर्म ऑफ सर्वाइकल इनकॉम्पिटेंस. सर्वाइकल इनकॉम्पिटेंस की वजह से मिड ट्राइमेस्टर अबॉर्शन होता है. उसमें पेनलेस जो है डिलीवरी हो जाती है. सेकेंड ट्राइमेस्टर में स्पॉन्टेनियस रप्चर हो जाएगा मेम्ब्रेन्स का. तो इस तरह का रहता है. तो उसको सर्वाइकल इनकॉम्पिटेंस देखने के लिए क्या मेथड है? तो एक तो ये होता है हेगार्स नंबर 8 डायलेटर विदाउट व्हेन द पेशेंट इज नॉट प्रेग्नेंट, इंटरवल पीरियड में. नंबर 8 हेगार गोइंग इजीली इन एंड आउट. Foley's number 16 catheter, you insert in the cervix, inflate it with 2 cc of saline, and you can pull it out easily, no problem. Shirotkar's method is like you insert a uterine sound inside, and it will go in and out easily without any pain. Through hysterosalpingography, you will find cervical funneling. Through TVS, you will find, while the patient is pregnant, cervical dilatation and shortened cervical length, the normal being 3.5 centimeter. So, and the last method is you insert a Foley's catheter, fill it with radiopaque dye, and you pull it and take an X-ray, and in the X-ray that bulb will be found in the, filled with radiopaque dye, will be found in the cervical canal. So these are all the tests to diagnose cervical incompetence. फिर मैनेज कैसे करते हैं? मैनेज करते हैं एनसर्क्लाज प्रोसीजर परफॉर्म करते हैं. एनसर्क्लाज दो तरीके से करते हैं. एक तो शिरोटकर्स प्रोसीजर है, एक मैकडोनल्ड्स प्रोसीजर है. शिरोटकर्स प्रोसीजर ज़्यादा कॉम्प्लिकेटेड है. उसमें हाई अप स्टिच लगानी पड़ती है अराउंड द सर्विक्स. उसमें ब्लैडर को डिसेक्ट करके सेपरेट करके फिर स्टिच लगानी पड़ती है. एक्सपीरियंस्ड हैंड्स में ही पॉसिबल है. और मैकडोनल्ड्स ईजी है, उसमें लोअर लेवल पे स्टिच लगाते हैं, और ऑल द 4 directions you take the stitch, tie the knot on the anterior aspect, and it has to be cut whenever the patient goes in labor, or like there is rupture of membrane, or like she turns 37 weeks of gestation. So that is what is the procedure. When it should be applied, it should be applied either at 14 weeks और जितना समय उसको पहले अबॉर्शन हुआ था उसे एटलीस्ट 2 हफ्ते पहले सर्कलाज प्रोसीजर करना पड़ता है. कॉन्ट्राइंडिकेशन क्या होता है? मेम्ब्रेन रप्चर हो गई, यूट्रस इरिटेबल है, ब्लीडिंग हो रही है, डायलिटेशन 4 सेंटीमीटर से ज़्यादा है, तो फिर इन्फेक्शन है कोई, तो सर्कलाज प्रोसीजर prohibited hai. Prior to performing a cerclage procedure, you should always get a fetal heart checked through ultrasound to ensure fetus is all right, okay, and integrity. And you should also see for the cervical length and all through the ultrasound. And then you should give tocolysis before and after the procedure, give proper antibiotic coverage to prevent any infection, and this is what. For the other anatomical defects like septate, you have to perform a hysteroscopic septoplasty. That is, you have to resect once you find that there are incidences of recurrent pregnancy loss in the patient. Like for Asherman syndrome, when there is a lot of adhesions inside the uterus, you go through the hysteroscope, break the adhesions, that is known as adhesinolysis. And then what you do balloon inflation post-op. Okay, so for about period of about 2 weeks, you put a balloon inside and give some NSAIDs and some antibiotics so that the patient can withstand the pain, and so it will prevent apposition of the uterine walls. How to manage the cases of genetic abnormality that I already told you. If some karyotyping and on karyotyping get an anomaly in the parents, you have to counsel them and advise them ART through pre-implantation genetic diagnosis. It is possible that a normal baby can be obtained. And otherwise, give folate beforehand. Before 3 months of conception, start folic acid, and you tell them about prenatal diagnostic tests if they are bothered about the recurrence. So these tests can be performed and you can find out whether the fetus is all right or not. And you have to give emotional support to the lady. Okay. Also check for rubella vaccination and vaccinate if not already given. Thanks for watching.